For always getting some more people. So how long should we wait until 8:05, or you want to do 8:10?
Yeah, sure. You could probably give it another minute. Usually it can take everyone a few minutes to get signed in. And then, yeah, whenever you guys are ready.
Okay. I think we should start now, and it's going to be anyway recorded and available for fellows and residents at this site, at the website. Are we ready, Martin?
Yep, I'm ready.
Okay,
Yep.
good. So good evening. Thanks for attending the webinar. My name is Ricardo Munares. I'm associate professor of urology at Boston University, and I direct the Center for Sexual Medicine and also a fellowship in sexual reproductive and transgender fellowship at Boston University. My co-panelist is Dr. Martin Gross. Martin is a former resident and one of my dearest friends and research collaborators. He has written with me over 30 publications over the last 3 years. Dr. Gross is currently assistant professor of urology at Dartmouth Medical Center, and he completed his urologic training at Boston University and pursued a fellowship in prosthetic urology under the mentorship of Dr. Henry. One of the reasons why he is here today is, number one, he's an avid investigator in the field of prosthetic urology, and two, he has participated in several sub-sponsored studies investigating the value of cadaver lab training in urologic education. Lastly, is because he's one of the few surgeons that has first-hand experience with the hydrogel penile model developed by Dr. Gassi. And our speaker is Dr. Gassi. He's assistant professor of urology at the University of Rochester and founder and director of the Simulation Innovation Laboratory at the University of Rochester. He completed his medical and urologic residency at the Cairo University in Egypt and pursued several fellowships in minimally invasive surgery in Paris, Austria, and Rochester. To further enhance his educational background, he completed the George Corner Dean's Teaching Fellowship, the Harvard Macy Institute Program for Educators in Health Professions, and a Master in Health Professions Education at the Warner School of Education at University of Rochester. Wow. He founded and leads the Simulation Innovation Laboratory, which is a research facility staffed with biomedical engineers that combine 3D printing and hydrogel polymer technologies to fabricate realistic procedural models that replicate the texture, appearance, and tissue reaction of human organs, as well as incorporate metrics for evaluation and performance. Dr. Gassi collaborates with national and international educators to enhance the role of simulation in surgical education and has received many national and international awards and grants. Dr. Gassi believes in a reciprocal relationship between research, teaching, and surgery, and translates basic and clinical research into a safer surgical environment with reduced surgical errors and improved patient outcomes. I'm going to leave Dr. Gassi give us his lecture on the future of urologic training and prosthetic training. Okay.
All right. Thank you, Dr. Menares, and thank you, Dr. Gross, for really inviting me to give this presentation. It is truly an honor to be, part of this work, and we've collaborated with Dr. Menares in developing this model, and collaborated with both of them, Dr. Gross and Dr. Menares, in validating this model. Today, I'm going to show you, or kind of walk you through the pathway of development of this model. And there is always a reasoning why we look at simulation. And the biggest issue is that we are looking at a balance between two main things, because the standard of care for simulation training in prosthetics or penile prosthetics is using cadaver labs, which have been very useful and have been something that still is considered the standard of care. But then when you look at the work mandates that are required, a technically demanding procedure like prosthetic surgery, where there are many critical errors that can turn the procedure into a complication, that there is a need for stronger training programs and the availability of expert educators. Like you have two on the panel here that are considered experts in penile prosthetics. However, that is not something that is common in nationwide, and it requires this exposure to these national experts in order to enable people, and this is usually through fellowships, to become prosthetic implanters themselves. Add an additional burden, which is really now weighing on us, is COVID, something that has definitely hindered these labs, or the cadaver labs, where a significant number of people collect in one area, traveling across state lines. This has definitely hindered the ability of us to develop further cadaveric labs and train people in using this technique. So there's a growing need for alternatives for penile simulations, and this is to expand penile prosthetic surgical training. And when we look at a model, we're looking at a model that is, relatively accessible, relatively cheap, non-biohazardous, meaning you can utilize it in any situation or in any area. You don't need a prepared lab or a prepared facility in order to accommodate this, but also procedurally and texturally sound. So the objective of this talk is to walk you through the development of this non-biohazardous hydrogel-based model for penile prosthetic surgery. After it's developed, we evaluated the impact of this hydrogel-based penile model as an alternative for platform for penile prosthetic surgery, comparing it to cadavers, and then examining the utility and feasibility of a remote training protocol for surgical skills using this model, and a software called mixed reality or merged reality. So in the development of a model, during my master's, we developed this technique, and this has been something that has been published. We used several experts, including Dr. Menares, and several international and national experts in development of this model. What we did is we broke down the actual procedure into what we call a hierarchical task analysis. And this is using our techniques in building these models, we were able to customize it based on the needs for surgeons. So to get the needs for the surgeons, we started with what we call a hierarchical task analysis. And basically this breaks down every single procedure or task of the procedure into anatomical landmarks that are required for that certain task, a detailed sub task for each of these major tasks, what instruments we need to utilize during this task, and what errors can occur during these tasks also. After we detailed that, we then built what we like to call engineering deliverables. So we took the consensus from all these experts and started to break down what is required in the model. So we break down the model into now anatomical components like skin, dartos fascia, urethra, the corpora. We are looking at the anatomical relevance of each component of these. The tissue fidelity, meaning the reaction of the tissue to different sutures, different manipulation, different dilators, for example. Also, the physiological fidelity. And this is mainly around the errors that can occur as a result of the step that is required to be performed here, but then methods for detection of these errors, because simulations are only as good as their ability to detect errors. And this is a way of evaluating performance, but also to looking at the progression of the trainee through their training pathway. Once this was done, we developed what we call computer-aided design. And after that computer-aided design, we then went into developing the actual prototype. And this is a prototype of the model itself and Dr. Menares doing the procedure. And you can see we focused on the ability of the model to replicate each component or critical component of the procedure. And this was not a model that was created once and that was it. This is several prototypes where we use iterative processing, where we develop a prototype. We had several of these experts try it, and then they sent us feedback saying, this is not accurate enough, or this is too rigid, or this is too soft, or the oozing that happens from the corpora is too thick or too thin, and this doesn't simulate what we consider something like blood, or the feeling that you get from using each part of these, or using the instruments to actually perform these procedures. So here you're seeing the ability to dilate the corpora both distally and proximally. And we went through almost 4 prototypes until we were able to develop this model. But even after development of this model, we are still continuing to improve the techniques that are required to fabricate these, but also improving on certain aspects of feedback that we continue to get. As we know that like placing the reservoir is one of the most challenging parts of this procedure in anatomical relevance, but also an ability to place the reservoir in the correct location without causing any injury. And this is something that we strive to really perfect, because it required printing of a bony landmark for the pubis, but also placing it in a way that it doesn't shift while we are actually placing this reservoir. The blood, or the fake blood that you can see there, is something that we wanted to also introduce. And some people might say it's too much or too sticky, and we still get that feedback, and we're trying to perfect it. But having an aspect of dealing with a fluid or dealing with a substance that is in the corpora is essential for the trainee to feel that exact realism, that then they can take that skill that they learn in this simulation and transfer it to the real task. So the closer this simulation can get to the actual real task, the more likelihood that the trainee is able to transfer this skill over to the live environment. Placing the scrotal component, or the pump itself, was also something that took a little bit of time for us to develop. And Ricardo, if you remember, very early on, we had this very tiny scrotum without any testicles, and we had to widen it and develop it and place almost fake testicles so that the pump can be placed posterolateral. We improved significantly on the Dartos pouch also, because the Dartos was something that was essential for this part of the procedure. After the trainee is able to actually finish placing the implant, they're able to test the implant and see the actual erection that has happened, or the rigidity or the turgidity that occurs. Skin is still a significant component that we have to deal with, because the closure is somewhat challenging. But again, like I alluded to, surgical errors are a very important component of this, and you can replicate perforation if you put too much tension into it, or do a perforation in the wrong direction. Injuring of the external iliac veins was also something that we wanted for ectopic placement of the reservoirs. And rather than have a bleeding vessel, we just placed a vessel with an inner and an outer color differential that when you look at it, you can see that it got injured, and also injury of the urethra, which is a common thing that happens during these procedures. So we developed the model, and then we had a significant number of, at that time, it was still pre-COVID, and we were able to team up with Coloplast in their cadaver labs and have the ability of getting feedback on these. So we had all the experts and all the novices, which are about 12 per lab, be able to perform this model and give us feedback on a response on a Likert scale of 1 to 5, telling us how realistic each part of the procedure is. And here in a graphical representation, you can see that based on these different steps of the procedure, we still have work that we need to do in the pump placement. We still have work that we need to do in the reservoir, but a significant proportion of these steps for realism, the ability of the model to replicate the steps, are over 60%. And some of them are actually over 80%. So showing that in certain steps, this is very realistic. Dilatation and the measurement of the prosthetic was something that was considered very realistic. And even the reservoir placement was graded as one of the top steps. we look at the other steps where we say that, pump placement, the corporal closure, and the skin closure is still something that we are consistently working on. And like I said, with the improvements that I had mentioned after we got feedback from Dr. Menares and other experts, we were able to modify that and improve these rates. Okay, slide. All right, so what we wanted to do is also ask these experts the value of this simulation platform. What value does this non-biohazardous simulation platform actually add to compared to cadavers or compared to the standard of care? And a significant number of the experts came back saying that its non-biohazardous nature was one of the top reasons why they thought this was very important to have, that is able to replicate different tissue consistencies, because with the cadaver, you still have kind of this monotonous tissue consistency that is sometimes there, even though they're fresh frozen. The fact that it is equivalent to the cadaver from a procedural standpoint, and that we can have now complicated pathology. We're already in negotiations and talks with Dr. Menares and other experts about creating, the version 2.0. Can we create a model that is more difficult, that has fibrous corpora, that has a previous implant, that, for example, a perforation happened during the dilatation of the corpora, and how would you correct that? Because these are all important things that happen in real life that you have to troubleshoot, and this model can be a perfect platform to do that. Regarding its educational impact and value, it was definitely seen by all the experts as a great training tool, but also as a good assessment tool. For certification, it was something that is considered something that we still need to work on, because to use this as a tool in order to certify a surgeon requires a very high level, a very high benchmark. And the fact that it can be done prior to live procedures to assess the trainee's ability to perform the procedure, i.e. its predictive validity, is still also something we need to work on. An interesting question we asked, and we asked experts, how many do you think that this should be mandated or not mandated prior to trainees doing live surgery or assisting in live surgery? And a significant portion of them, almost 2/3, said, yes, it is something that I would consider mandated if available. But also, when we looked at the number of models that these experts felt, they felt that almost an average of 3.5 models prior to live surgery was something where experts would feel that they would be comfortable having their trainees actually perform a significant number of procedures after doing these number of models. When we look at after we evaluated the model and felt that the model was something that has true educational value, is realistic in different components of the anatomical components, but also can replicate the procedure itself, we then looked at performing a head-to-head comparison with cadavers. So we took the models to the cadaver labs, and rather than have them being done separately, we had them being done in conjunction. So every trainee or every person attending the lab got to do a hydrogel model and then got to do a cadaver, and vice versa. So we had a total of 29 participants so far. Of course, you can imagine that COVID definitely put a wrench into these efforts. So we were able to get 29 pre-COVID, or a significant number pre-COVID, but also we continue to do them in limited numbers in COVID, during the COVID era. We had 6 experts, 11 fellows, and 12 residents, and they got surveys in response to their doing the simulation on the cadaver and on the hydrogel model. And we were looking at realism, the ability to replicate procedural steps, and its educational impact. And here, this is the comparison. The question was, do you think that this model can be compared to a cadaver model? And it was on a Likert scale of 1 to 5, where the 5 is considered something where it is better than the model, or at least equivalent. And these are the responses that we got for 4 and above. And everyone felt that, the skin, the fascial layers, the pubic bone, the corpora, the inguinal canal, again, is something that we need to continue to work on, especially the spermatic cord. But in reproducing the procedural steps, a significant portion felt that it could reproduce all the critical components of this procedure itself, with the lowest one being 79 and the highest being 97 in the prosthesis placement. When we asked them that regarding its utility, all the experts and fellows, because those are the ones that actually do the procedure on a regular basis, felt it was useful for improving technical skills, teaching the procedure, and assessing procedural ability. 67% of the experts felt that the hydrogen model was same, if not better, than the cadavers that were there. And 79% of them agreed that this could be an adequate training modality for prosthesis training, for penile prosthesis. when we looked at their ability to utilize this as an adjuvant for to cadavers, meaning that these models would be available with the cadavers, we have 83% of the experts, 91% of the fellows, and 67% of the residents felt that this is a useful adjunct, but not only useful adjunct from a procedural standpoint, but it was also safer as it is non-biohazardous and does not expose you to a cadaver. 1/3 of the experts, and this was very, this was shocking to me, 1/3 of the experts said that they preferred the models over the cadavers itself. And this is mainly because of ease of accessibility and not needing specialized facilities to perform this. When COVID happened, we decided that we wanted to look at a way in which we could almost replicate these cadaver labs or these educational sessions using a technique that is not really where it doesn't involve a face-to-face encounter. So we were looking at remote training. And for this, we needed a model that was non-biohazardous, but we also needed a way in which the expert and the novice, which is more than Zoom, can portray their feedback. So we wanted to look at a protocol, and we looked at this in a very scientific way. So we wanted to offer some pre-learning materials, meaning that we wanted these trainees to come in having already some level of knowledge on what they're going to do rather than do it the first time. Because again, no matter how sophisticated you can get with remote training, and I myself, in my master's, I have an online certification, so certified to give online courses, it is very clear that you cannot give them the same level of feedback and training that you would get in face-to-face encounters. This is just human nature. So you have to supplement that by having a significant amount of pre-learning. And that came through a procedural script with a PowerPoint presentation and also a video demonstration. And me and Ricardo were just, Dr. Menares were just talking about this video. He has done a very high definition, very high level video on the model. And we're working now on kind of breaking it up into small pieces. And this would be offered to the trainees prior to that, explaining, doing a detailed step-by-step explanation of the procedure. And that is very important for them to be able to accommodate the feedback they're getting in a remote environment. The next thing was we wanted to set up a remote setup. And this is including the non-biohazardous model. So this is something that can be shipped to anybody. And it also, we needed to set up a way in which the trainee itself, with their instruments and with the video, that the instructor can get the feedback, can get the video feed that is high definition and detailed enough that they can give them feedback. And finally, we found a software that enabled us to do optimize the feedback between the instructor and the trainee. But we realized that this was something new for these instructors. So the instructors undergo some level of training on this software so that when they use it with the trainees, they have an idea of what are the options that they can use for it. So this is the instructional manual that is developed by Dr. Menares, and it's a PowerPoint presentation about 24 slides. This is not the high definition video. This is the video we have. We're still working on the high definition video, and this would be sent to all the trainees as a pre-learning material. So everybody has to watch this in order for them to understand what they're going to learn. Then we ship a package over to them. And this is, again, thanks to our sponsors, an educational grant from Coloplast. Coloplast developed this Pelican bag or Pelican box that you see the model up here in the left. These are the Coloplast, the Titan Coloplast prostheses. This is the camera. This is the remote that's used for the camera. And this is the boom for the camera. So it's all set up in one kind of bag that is sent over to the Pelican case that is sent over to the trainee, and the trainee opens it. And this is kind of their setup. And they have instructions on how to set all these up. We also wanted to use a setup for the trainee and the expert. So using this software, we needed cameras that enabled us to have the trainees record what they're seeing from an overhead view so that their head is not getting in the way, so that the trainee or the instructor can see their video feed. But at the same time, they needed to have a laptop in order to see the surgeon or the instructor giving them feedback. If you look at the instructor, on the other hand, we used what we called merged reality software. And this is a software where when you set up, it's a cloud-based software, when you set up a webcam, the surgeon now is able to kind of put their hand in there, and that overlays on the actual video that is occurring on that laptop that the trainee is looking at. So they're seeing the surgeon's hand in the process. And give you a sneak peek of what this is. So the blue gloves, this is the instructor in a remote environment, and their blue gloves are overlaid onto the actual picture. So the trainee is doing the procedure, they're actually looking at a camera or a screen and able to figure out where their hands are. And you can see here, they're able to give very detailed instructions. Look at, so this is Dr. Gross with one of his trainees. So you can see that he can give very detailed instructions using this overlay while being in a very remote location. But at the same time, here you understand the value of this pre-learning. So they have an idea of what steps they're going to do. Here is, for example, putting the reservoir, which is a complex part of the procedure. So this is basically done in a conference room, and Dr. Gross was in his office, and he was able to give detailed feedback to this trainee in performing the steps of the procedure. You can also, if you see here, these are annotations, so you can actually draw on, so the instructor or the can draw on the actual screen and give them highlights on where they want to go. But we've realized that surgeons are very, we use our hands a lot, and therefore that is where we realized we have to wear different levels of gloves. Again, looking at the pump is again another complex part of this procedure. And we've seen trainees overlay their fingers. So, Dr. Gross is pointing in a certain direction, and what the trainee is doing is now kind of orienting their fingers in the same direction to get where they need to go. So they were actually dissecting laterally, and now they're dissecting where in the plane that they need to dissect. Yeah, one part I wanted to show, which was very interesting while they were putting the reservoir, Dr. Gross was explaining how the reservoir gets placed itself in the actual, how they're able to place the reservoir, how they have to cup it. So he's explaining with his hands how to actually position the reservoir in her hand. There's it. So you can get an idea of how we can utilize this. The surgeons, based on their feedback, felt that this was an adequate way that they could give feedback. We've only done 4 sessions so far on this. It's been a very promising tool to offer remote feedback. To tell you the truth, the residents loved it. Why? Quoting from them, one of them said that this is the time where I get to do the entire procedure from the very beginning to the end. There is no surgeon takeover here. They can't take over the procedure. And at the same time, they're able to get this detailed feedback that they don't get stuck in doing this procedure. So I see that this is, this technique or this, using the non-biohazardous model in addition to this software, this could be a future way in which we can not only do, remote training while we're in the same institution in a remote location, but we can do it across national borders and maybe even across international borders. I can imagine us being able to do these simulation educational sessions with models around the world, and at a certain time we go live, and through this webinar we're able to give feedback to several people. We're still working on being able to have more people enrolled in this and getting detailed feedback on what we can do to improve, because we do believe that there is room for improvement. But we have to say that this is a great start that allowed us to continue training using these models and using these educational content without needing to do face-to-face sessions. And that wraps up my talk till now.
Okay, we're gonna open for questions. So Martin and I, we have had the luxury of working with Dr. Gassi from the very, very beginning using this model, and there's been a clear evolution of the model. Initially, the scrotum was not big enough, and the material, the dartos was not there. So there's being a continuous evolution of the device, which it makes it more realistic and allows for repetition of pretty much all the steps in a simple penile prosthesis model. So right now, I feel that I can teach with the model all the steps of a simple penile prosthesis. Obviously, this needs to evolve where we can simulate complications or difficult cases, but this is a very good model to teach residents to practice. And with the addition of the software, then we can use it not only for teaching, but even for an intra-op consult from the distance. So this combination of technologies, it's amazing. And I think it will certainly enhance the field of prosthetic urology, especially because the number of experts or people who do routine prosthetic surgeries in the US and Europe is really minimal. And it doesn't meet the needs worldwide. So this will hopefully help us bridge the gap, at least for a decade or so, until we get more people comfortable and doing this procedure safely. So I don't know if there are any questions. Let me see. There's one here. Can this model be used more than once?
Yeah, so we always kind of balance this, what we call durability and realism. So the more realistic something is going to be, the less durable it's going to be, and durable is the number of times you can utilize it or reuse it. We decided to go with realism, and we pushed that to the extreme, and therefore you can only use this once. And that is one of, I wouldn't say the drawbacks, because it is very realistic, but the idea is you only use a cadaver once, right? So this model is very similar to it. You can use it only once, but it is more accessible and relatively cheaper than a cadaver. And actually, one of our residents, Michael Whithouse, who I really want to mention here, he was instrumental in developing this model with us and with Dr. Ricardo during his research year. But he also did an interesting cost analysis, which we are still working on getting the data for. And he found that this was 67% more cheaper, because you don't have these non-biodegradable costs and the costs of this hazard where you have to kind of throw everything away. So I would say we want to keep it one time, but we want to make it more useful for, like Ricardo said, different utilities. So use it for a simple, maybe on one side, and then a complex ectopic placement, because you can put two reservoirs, right? You have two inguinal canals. Make one side where it's actually a straightforward reservoir placement, and then make the other side an ectopic placement for a reservoir, so they can learn both techniques. And that would be very interesting to increase the utilization or the utility of this model for different approaches.
If may add, although we only talk and most of the material was developed for penoscrotal, the reality is that we can do an infrapubic, and we didn't talk about it, but I've done it. So this model allows for do a one penoscrotal case and a subsequent infrapubic approach. So the realities can be done with maximal utility or maximal benefit with twice. So you can do easily a penoscrotal and then an infrapubic or vice versa. And the technique is similar, and the outcomes are very similar too. So it can be done both ways.
And I want to emphasize Dr. Ghazi's point. I mean, we've all done cadaver labs before, and the cadaver labs, those cadavers are blown apart after an implant and a half, and sometimes even after a single implant. So, you know, that these things are usable once or twice if you do infrapubic and penoscrotal, because I think light years ahead of what you're trying to get with a cadaver, where the tissue planes aren't the same, and you know everything is kind of messy, even after just minor tinkering with stuff. I think the other thing that's important about these is, you know, in cadavers in particular, I mean, as medical doctors, we've spent centuries, you know, figuratively and literally digging up the dead, you know, and so even the process of, you know, now, you know, getting cadavers for these events and doing those stuff is a monumental task of labor that really limits the amount of labs you can do. And having the again, as Ricardo said, the luxury of being able to, you know, procure these models easily and effectively, and I would say probably more cost effectively in the long term, is really a quantum leap for these as compared to previous, for sure.
So Mike actually is online, and he's listening to us, and he asked if we can comment on the utility of the model for teaching troubleshooting situations like proximal perforation, distal perforation. So that's a very good question. What is the next step? How complex can we go from here? So the initial attempt, I think that Dr. Gassi and all of us involved in the project is to develop a simple model to teach people how to do efficient and safe penile prosthesis. So that's the first goal. Having said that, this model is complex enough that would allow us to advance and do other techniques. So we can do ectopics, we can do a proximal perforation, we can do a distal perforation. Dr. Gassi, during the 3D printing, it can make the corpus more dense or less dense, so it's easy to perf, or more fibrotic, so we need to use cavernotomes. So we hope that in the near future, we can have a model for difficult cases or for managing complications. Some of the current complications right now can be managed with this model, or can be taught how to be managed at this point.
And I think the other thing, Ricardo, is you know, as people who do this a lot, we sort of forget what people don't know. And you know, for residents, for medical students, for people who are out, you know, in practice, there are huge gaps in the knowledge of this procedure. And even just having a baseline method of being able to teach people how to do a simple implant is also pretty revolutionary, and definitely very useful in being able to sort of broaden the ability of people to learn this this procedure, for sure.
So you know, this can also one great value that we have is that we are trying to one of the society's subs is developing a fellowship curriculum for prosthetic urology, and one of our goals is to give some type of certification for fellows and attendees on prosthetic urology. So our goal is to develop education material with which we're doing. Actually, Martin is one of the persons involved in that, and then do make sure that the fellows attend, or the residents attend, a cadaver lab training. And then finally, there would be a potentially test that we can use one of these models on remote coaching and a remote evaluation, because it could be one of my residents doing the model, and Martin can be miles away evaluating my resident. So I'm sure he's not going to be as benign as I would be, so with my own residents. So it has the ability, hopefully in the future, to be a valid tool in certifying residents, fellows, or even people out there in private practice who are interested in prosthetic urology.
Yeah, I agree with you. The idea is, you know, our problem with training is multiple fold, but one of the issues that is access to experts. And, you know, there is this need for trainees to have experts, like you and Dr. Gross, and the ability of having this remote kind of feedback session during hands-on training. So remote feedback has been available for centuries, right? For decades. The ability to kind of watch a video and give it the feedback remotely or through Zoom, but the ability to actually see that while you're doing hands-on training is definitely something that we're touching on that's new. And I do feel that part of this certification could involve, hey, here's a model, let's evaluate it. Let's evaluate your performance on the model and see if you are safe to get this certification, while at the same time giving tips and tricks from an expert. And here, you don't need to do this on a patient. You don't need to do this on a cadaver, because there are a significant amount of regulations, even in the US, across state lines. Are you certifying somebody? So are you legally liable for a complication that happens in live surgery across a state line? That's an issue. But if you're using a model, this is something where you don't really have that liability, and it's realistic enough that you can see how competent this person is. So there was a question, I think, that came up regarding, can you assess competency? Yes, one of the things that we're going to develop also together with this great team is to develop a checklist through which we can evaluate. So you get a score at the end of the actual performance of this, and you can say that based on this checklist, you are competent, or you perform these areas, or you need to work on certain steps of the procedure that in order to be competent. So evaluation of competence is, you have a procedure that, or a platform that allows you to replicate the model, but you also need a scoring form or a checklist that enables you to enact that.
And I think the access to experts part is crucial. One of my chief residents right now went through a large bulk of his residency with really no interest in prosthetics. I did not inspire him to the degree that I was hoping. And then he went to the SUPS cadaver lab and met this real powerhouse setup of multiple magnificent people in the field, and came out with a fervent desire to start doing a fellowship in prosthetics, and is now going to work with Aaron Lentz down at Duke. So it's really exposure that is crucial, and I think that this is a tool that can broaden exposure quite a bit, and broaden exposure to people who love and have a passion for what they do in penile prosthetics.
That's an excellent point.
One thing that we have realized is that when we started to do our remote teaching experiment, is that we realized that to take this to the next level, our educational material has to evolve. So we are in that process. It cannot be a simple slideshow step by step. So we're creating a video of each step with a mini second, 3 seconds on how to do a particular step. But we also realized that some of the residents were capable of doing the surgery, but they were unable to put together the implant. So we have to also create content on how to put it together, how to drain the air, how to get it with saline, how to put the rear tips, all this kind of stuff. So as we evolve in the model, we're realizing our deficits on how to improve the educational material. So when the residents, the fellows, or people in prior practice get to this level and they read the educational material, they're as close as they can to perform good surgery. So educational material is key. This is being developed with the collaboration of many surgeons, obviously industry, our partners at SUPS and SMS, and so on. And we'll take this over and over until we get something that is reliable, reproducible, and hopefully economical or cheap.
Yeah, you bring up a great point. One of my mentors doing my master's in online education always told me that online education brings out the weakest part of your kind of educational content or educational delivery, because you said it, like when you're doing these face-to-face sessions and you have these implants, somebody's prepping that implant for you, and it's in the back of your head that someday you're going to prep it yourself, and you might not be prepared to. But you're when in this remote training environment, you realize that I need to do every single step and be able to do every single step and do it myself without somebody kind of putting their hand in there and showing me how to do it. So it enhances your ability to educate. However, it will only do that if you have the right material. So I'm with you. This pre-learning material and this education material that comes with this remote training session is not only a luxury, it is a key and essential component of them being able to actually get this feedback. Because you can imagine somebody that doesn't know anything related to prostheses and you're trying to remotely give them feedback, it's not going to work. It is almost like we said, a protocol that comes together, and the remote training and the software is a component of that.
So for example, in the material, the videos that we recorded, we did step by step how to prepare the devices, but we also introduce the not touch technique and how to cover the surgical area. So we are trying to not only teach the absolutely technique, but the goal is to develop enough content to do this safely and to minimize infections. So it's not only about the technical procedure, but everything that is around it, infection prevention, hopefully in the future, infection management with the salvage and so on. So it's interesting because the more we look at the model, the more we realize that we have to do and improve our educational content. I don't know if there are any other questions. Where you see, what is the biggest limitation of this model to take it to a big scale?
Yes, so great question. And I was expecting that. So this is now almost a piece of art, right? It is a handmade, customized model that is developed using engineers and high-level technicians. In order to take it to the manufacturing level where we're able to pop out a significant amount of these models, in a short period of time, we have to start. Number one is to standardize the process. So there are still a couple of pieces left, but I think almost 80 to 90% of the model is standardized, that this is what we need to do to develop this model. And the more exposure we get with the model, the more likely we'll get feedback. Then we need to kind of look at ways in which we can utilize, 3D printing is a great tool, but that's not the only tool we use. We use a significant amount of registration and certain fabrication techniques. I would say if the demand is high enough, then the ability to make these, we'll streamline the process where we have partners in manufacturing that come in and tell us, hey, this is what you need to do to cut down on this step and this step and this step. And we're actually already starting to do that in the lab. But again, this is a research lab. In order for it to be done truly in a manufacturing way, you would need to kind of have heavy machinery and different types of experts that enable, there's an art of converting something into a manufacturing assembly line, and we need to work on developing that. Once that is done, then I think these models will be not only available, but abundant to a significant number of people. But we don't want to send out something that is not yet perfected. And even though 80 to 90% of it is ready, it is not perfect yet. And so we're encouraging more people to be able to utilize this. And this is done through different of these cadaver labs and to different educational seminars. And we have an educational grant again from Coloplast that provides this. So it does allow more people to be exposed to this. And once we reach this level where we feel it is the correct time to start to then turn this into a manufacturing process, which does decrease a little bit of the realism, we will then be able to do that and it will be readily available.
Technically, what at the present time, the model, what do you think is the next improvement that we need to do? What is the next?
Yeah, so I would say we need to kind of perfect the idea of the inguinal canal area that is the weakest area, and the part of it is related to just we need to print more of the bone, and that just makes the model a little bit larger. But we're again soliciting expert feedback to be able to take care of that. But my interest in the next steps is creating kind of a customized model where a component of the model is a little more difficult. So all the models that I've seen, everybody places the reservoir on one side and that's it, right? We're done. Well, there's this other side that we can almost utilize to kind of give them another level of competency that wouldn't be available in a cadaver, wouldn't be available or would be rarely seen. Like, for example, ectopic placement or a different way of placing the reservoir. Same thing is, there's no reason why we cannot create a corpora that is fibrosed and a corpora that is normal in the same model, right? Because these are customized models. And this is the beauty of this. So they would dilate on one side freely and normally like they would. And there's like, so this is what it feels now when you dilate in fibrotic corporas, or, perforate the proximal, the posterior part of the corpora on one side. So then they learn how to use that technique with you with putting the posterior rear tips and being able to suspend them with sutures. So giving them a little bit more than being able to just do the model. And this requires somebody that's already done the model. So a trainee that's done the basic model. Now we're looking to look at the model 2.0, where there's a little bit more advanced skill that is required in these models for you to be able to do it. So you did part one, now you come and do part two, where it's a little more advanced, you learn a little more advanced techniques. But for that, again, we're trying to standardize one model and put it in production, but we'd be interested in kind of looking at what difficulties or what would we say challenging steps can we introduce in future models that enable this to not, enable these trainees to not only get the basic skill and be safe when they're doing this, but also take it up a notch?
I'm looking at the list of attendees, and I see a dear friend, Mauricio Delgado. He's from Colombia. And I wonder how he would take this model, because right now in many of these countries in South America and other parts of the world, there are no real cadaver labs. So when they want to attend, they have to come to the US or Europe and then to do some of the labs. But this can be safely shipped to those countries, and we can do remote teaching. So it has also a tremendous value, I think, for underdeveloped countries that are still doing prosthetic and other surgeries. So
I think it also has a value for experts. I mean, as much as I enjoy traveling to far-flung exotic locations to teach people how to do implants, I could be doing that from the comfort of my own house or from my office, and that is really a remarkable transition. I think you make, not only are you benefiting trainees with this, but you're really benefiting educators with this as well, by giving us opportunities that we wouldn't otherwise have, that are also, convenient and safe.
It's also it gives you the ability to do a different type of training, because you can do the educational material, they can do the penal models, and then you can, when you travel and you meet them, you can do live surgery with them. So it's like a continuous education until you do live surgery in other countries. So it's like allows the attendees to evolve to a level that by the time you go there,
step-by-step fashion,
by step, by the time you go and visit them in Russia or whatever you're going, they are pretty much capable of doing the surgery, and you're just kind of there to supervise. So I think it's a very interesting technology, especially for places where they don't have the luxury, have experts or high volume implanters that can teach them any day of the week. So I was looking at my experience. I went to Russia a couple of years ago, and this would have been great if all the attendees would have listened to the lecture, see the video, the educational material, do a couple of penal models, and then we do live surgery together. It would have been a completely different experience. And I'm sure the level of comfort by when I finish and I leave would be completely different than just going there and doing the live surgery for them.
Yeah, that's a great staged approach.
I think the other thing also is it gives us yet another avenue to validate that what we do in labs and what we do to teach people is actually useful and productive down the road. Ricardo and I have been involved in a couple of papers that talk about the utility of the SUPS cadaver lab in giving residents and fellows increased comfort in the procedures. And having a model in there with what is a very rigorous and systematic pre-production and production, that it's consistent every single time, means that if that variable is secure, the only variables we have to measure from now on in research are how the attendees to these labs, or how the participants respond to these, and how the results they deliver show increased comfort and validation with the procedure. So it really makes education and research and education it's hugely benefited.
I don't know if there's many more questions or comments. Obviously, what I love to see is a massive production of these devices, so it's available for residents, and particularly, I think, being in academics and being at a referral center, to be able for private practitioners who don't do that many implants on routine basis, but they want to continue them, having access to these models, it can be key for these providers, which is something that we have not discussed. There are low volume implanters that do 5 or 10 a year, and with that volume, it's very difficult to evolve or to even keep your skills. But with this model, if they're going to do 2 cases, one of these models can be shipped, they can be proctored, and believe me, the patient is going to be in better hands. So even for just prior practice, this is an amazing tool that hopefully people will have.
Totally. I mean, when we had Dr. Clayman as a visiting professor a couple of years ago, and he discussed how in the laparoscopic world, the laparoscopic training has, obviously been of tremendous benefit to helping laparoscopic surgeons along, but more specifically, that you have sort of a laparoscopic trainer that day or the day before you go in there and brush up your skills and then take those skills in the OR. Means it has been demonstrated to show that surgical outcomes are then much better for those patients. So this is, I think, an avenue that we have not had in penile prosthetics in the past that really is very, very different, very exciting.
So I think there are no more questions, and I don't know if you have any final word to Dr. Gassi and Dr. Gross.
I think we covered it all. It was really a great discussion, kind of talking about the model and its utility and the future aspects of it. And this is really great.
And I think I want to commend both of you. I mean, I certainly know Ricardo very well. I know that he's a master educator. And Dr. Ghazi, I've been extraordinarily impressed with your innovation and with your educational expertise is phenomenal. So between the both of you, I think it's an excellent partnership and one that I'm more than happy to bask in the glory of in coming years. I think I'm very impressed with your guys' productivity and outcomes so far.
Thank you. Thank you for
Okay,
being part of it.
I want to finish by thanking SMS and in particular the Educations Committee for organizing this webinar and for inviting Dr. Gassi, Dr. Gross, and myself to give this lecture, this webinar. This will be obviously posted in the website, and obviously all three of us are available for any questions that can happen. Just send us a text or an email and we'll be happy to answer. Thank you very much.
Anytime. Thank you.
Excellent. Thank you.